Hello, everybody. For those of you who don't know, my name is Rob Odell, and I'm the founder and CEO of Biotech. We are a nationwide distribution company with a focus in regenerative medicine, medical devices, and more in the wound care, orthopedics, and aesthetics markets. We exist for one reason and one reason only. We exist to change lives permanently and for the better. And we believe that everything we do today has a direct impact on tomorrow. I wanted to talk a bit today about the 2026 payment policy regarding skin substitutes. This has been a hot topic in the market. Obviously, there's been a lot of volatility. This has been something that has been working for quite a while. So I want to focus on some of the facts, what is true, um, break down that document a little bit more, and then get into potential next steps and what's to come. So here's the facts, right? What we do know since this document was published November 1st is everything will be implemented here January 1st, 2026. So between now and the end of the year, the policy exists as it is, payment policy that is, with the ASP methodology for skin substitute reimbursement. Beginning January 1st, we're seeing a reimbursement of $127.28 per square centimeter, which is a huge decrease to, I believe it's about up to $5,800 a square centimeter. It's climbed astronomically. This will apply to the physician office, the outpatient setting, mobile wound market segments. So let's break down this document a little bit further. I am not a regulatory affairs, just a disclaimer, I'm not a regulatory affairs officer. I have no background in law, but I do want to speak a little bit about what's some of the bones of this document, kind of keynotes. It was quite long regarding just the skin substitute payment policy. It was about 60 pages of both comments and replies from CMS. One of the things they talked about is products being grouped into three different categories based on regulatory pathways that they take to come to market. The first one is pre-market approval. We get into 510K cleared devices, and then what most of us know commonly in the skin substitute and amniotic space is the 361 pathway. So CMS had mentioned potentially in the future structuring it like this in order to reimburse these products due to the cost of entry based on the pathway they took. So kind of doing a tiered system of reimbursement. For now, everything will still be reimbursed at that $127.28 square centimeters, but looks like they're setting themselves up for potential pathways. I think the idea behind this is to continue to drive innovation and reward innovation. So we'll kind of have to see what comes down the pipeline with that. The LCD is still expected to take effect in January 1st of 2026. This CMS had kind of pushed back off to specific MACs to where they pretty much said in their document here that the point of CMS here was for the payment policy reform and not for the actual coverage determinations, and that should be left up to the MACs. They did strongly imply that the MACs will probably continue to go through with an LCD rather than an NCD. We'll get into that a little bit later in the presentation here. They also mentioned non-sheet products. I find this quite interesting because there's quite a few on the market, and the MACs kind of seemed, or CMS kind of seemed a little open-ended about this, right? How non-sheet products will be currently recognized as skin substitutes, kind of leaving it up to MACs on how they want to reimburse these products. So I do believe there could be some potential here. It'll be interesting to see how the MACs respond. They also had mentioned potentially creating policy regarding non-sheet products and how to bill for them, via unit or whatever methodology they come up with. And they continuously mentioned, I mean, here's the reality of it. CMS is pissed, for a lack of better terms. There was a continuous mention throughout this entire document about the exuberant Medicare spend. From what we've seen, and some of the projections of what's supposed to come by the end of the year is over $15 billion in Medicare spends just on cellular tissue products alone. We looked, I think it was a bit over $6 billion last year, so it's a huge climb, and Medicare spend, and obviously has put this entire industry and these products under CMS's kind of scope, for lack of better terms, and rightfully so. As you can see, that is a astronomical amount to spend on some of these products. So I really, this was the segment I really wanted to focus on, is what is some of the impact that is going to be had once this payment policy goes into effect. I think the most heartbreaking and heavy impact is going to be on patients and the access they're going to have to these products. And it's simply because we're going to see a big decrease, suspectedly, going to see a big decrease in utilization of these products in rural areas where patients are already limiting access, right? They may have critical access hospitals they can go to. Some of these patients are immobile. There is a lot of patients that aren't mobile, right? So they need some type of practitioner to come to them due to either the comorbidities they have or just their geographic location, especially throughout the Midwest. We've seen a huge spike last year in the mobile site of care. I think it was 125% plus in new mobile businesses coming to market, and increase in billing in the mobile setting. I think there has been an argument that things were fine before and they'll just kind of go back to the way they are. The tragic truth is things should never revert in medicine, right? Things were fine before the smartphone. Things were fine before the automobile. We've crossed a threshold in medicine where there's a different expectation of care, especially for patients who maybe didn't have access to care prior to mobile settings, or at least the level of care prior to mobile clinics and mobile clinicians reaching these patients. Also, and also to mention, the physician office obviously falls into the site of service that is impacted by this payment reform. And as a result, I suspect we will see a lot of clinics and businesses shut down. It's just not sustainable. I mean, especially going directly to patients' homes. I think that explicitly we'll see a huge reduction in, just for the pure purpose of revenue versus reward. I mean, to drive to patients' homes takes a lot of time, takes a lot of resource. You have liabilities that you won't maybe find in a private, a brick and mortar, right? You have now a car and the liability of that, insurance of that. And it just becomes a whole nother level of financial and fiscal responsibility that they're not making up for with skin substitute revenue. This one is an interesting topic that CMS didn't have, from my findings, a comment on, and they they answered quite just about all the comments people submitted. It was quite impressive. They really did. Not to say I agree with all the responses, but they did their due diligence in answering a lot of the comments that had been submitted to CMS. So potential outsourcing of raw material. This is definitely a concern from an ethics standpoint. You know, a lot of the tissue that is sourced here domestically is from the American Association of Tissue Banks. It's all very regulated. It is tracked. A lot of it is domestic. And one concern is, in order to keep manufacturing costs low, outsourcing raw material to foreign countries, potentially third world countries, where there is a high rate of poverty and potential for black market illegal trade, potentially exploiting individuals to source that raw material um, to sell to manufacturers here in the States. Now, while that may seem like a stretch, I don't really think it is that far off. It is at least something to be considered. Another thing I think that has been painful from industry standpoint is the the ask of CMS to spend or to collect data, right? We'll just put it that way, not even really clarifying what that data will be. Manufacturers industry spent a lot of money on RCTs and trials to get data submitted to CMS and the MACs to ensure that they're not only on that list of approved vendors, for lack of better terms, but to ensure that they're going to obviously still be a player in the space. And um, I think there was some expectation that the potential reimbursement based on data that was submitted by Dr. Tettelbach and other individuals would be higher, right? Just the fiscal data that was submitted was looking somewhere, I think, in the $400 to $800 per square centimeter range. And here we are, millions and millions and millions and millions of dollars later, and we're at $127.28, which is a little over $1 increase from the proposed $125 and whatever cents it was. So it surely has been quite painful from manufacturers' standpoint. Another impact to take into account as a result of this domino effect is if more patients are going to be treated on the inpatient, we're going to see an influx in HOPD traffic. Patients will start to head into hospital settings where hospitals are already understaffed, see a high rate of infection, um, maybe not equipped for additional traffic, holding up hospital beds. We'll see an influx in amputations as a result of inadequate treatment of limb salvages cases, and I fear that this will have a huge, again, impact on Medicare spend. Instead of preventative, we are now reactive in our treatment modality, right? In the HOPD setting. Another point of topic is lack of margins for commercialization. I put here sales forces, but just commercialization of products in general. Marketing, getting products in front of doctors, samples, labs, again, clinical data, trials, collecting evidence. All this takes time and a lot of money to do from an industry side. Not only that, but if there's not money to be made, there's not innovation to be had, right? I think we've had from an industry side, I think there has been some, significant revenue that has been pulled from the skin substitute market over the past few years. But if there isn't potential revenue streams or margins, I should say, uh, that are compatible with making an investment worth it, then we've already seen a huge decrease in an outside investment from VC and private equity. We've already um, we've already seen hesitancy from really any innovation due to lack of clarity on CMS's part, right? Requesting data without clarifying what data they want. Not sure on reimbursement policy. Healthcare as a market in general has kind of been this roller coaster, even if you look at larger indexes. So it's a lot of kind of shakiness. Another thing as well is there is no NCD. It's something during the reimbursement consensus panel that was talked about, and we'll get further into that as well after the IPALS summit. But this would expand access to Medicare Advantage populations, right, which we've seen a huge influx in. It's been a pain point between both providers and industry. Um, and this potentially would be huge. There has been no hint or inclination that CMS, at least in this payment reform document, um, was even considering that. So it's early to tell. I think that um, we'll have to kind of see, right? Fingers crossed with that. So what's next? There is a bill currently sitting right now in Congress, proposed by Senator Bill Cassidy, of a Payment Reform Act of the skin substitutes. Right now, the government is shut down, which delays any movement with really anything, especially this bill. So, quite honestly, until that the government opens up and Congress gets kind of back to work here, and reviewing some of these bills, expecting anything to change between now and the end of the year is quite unlikely. So there is a potential for lawsuits. This is something that is still kind of fresh. You have potential actions that can be taken against CMS to claim that the rules, the ruling that they had, been stated on the payment policies for skin substitutes is based on flawed data. We're really expecting to see, and this is something that has kind of not been talked about as much, considering that the reimbursement has been kind of the hot topic. But I would assume there's going to be a huge increase in audits and clawbacks, even more so than this year. We've seen a continuous spike. A lot of these are being denied on the first and second level appeals, sending them straight to the ALJ, which is, from my understanding, is really a crapshoot depending on the ALJ judge you get and the knowledge of what's going on in the industry. There is a lot of confusion and, unfortunately, um, misconception about the reimbursement, the payment, contractual structure between the physician and either distribution group or manufacturer. That's under a lot of scrutiny right now. So I only think it's going to get uglier before it gets better. Right now, I think we're in the eye of the hurricane. We are right in kind of the middle. I expect pretty much some calm between now and the end of the year. I don't expect too much to change with the holidays coming up, the government still being shut down. Um, any, bill that's going to potentially cross Congress' desk is kind of sitting there collecting dust right now. And I believe we're not through this battle, right? I think that this is we're in the middle of the war right now, and we're just in the calm sect of it. I think a lot, unfortunately, of patients will be the individuals impacted and suffering as a result of this payment reform beginning January 1st. We'll have to see the sustainability of practices, um, and how they can kind of pivot and hopefully still find innovative ways to treat patients. Um, to that point, as industry, the push for innovation. What does that look like? As I mentioned earlier, we've seen a big pull out from private equity due to volatility in the market space and just healthcare in general. And that goes for VCs as well. Um, and what innovations can we bring to the marketplace as an industry, right? And where can we also find potential revenue opportunities to make up for some of the missed revenue from the skin substitute market? What I can say for our organization is we are constantly trying to bring new innovations to the marketplace. We are looking to bring some pretty cool technologies that's in early stages right now. We did launch a hydrochloric acid, which is super, super exciting. This is really the staple of wound cleansing. It should be used really when cleaning, pre-debridement, post-debridement of any wound, to get that wound on a trajectory of healthy healing. as well as some ancillary products, which, dressing choices are extremely important during the wound care treatment process. So we have partnered with a great company to distribute different dressings in the marketplace as well, keeping costs low. So during this rough time, clinics can keep more revenue in their pocket, try and retain some of the working capital that they need to keep their practices sustainable. So I will leave here some QR codes. Please get in touch. Follow us on LinkedIn. We're constantly posting news, updates, um, phone number, email. We encourage you to reach out. We encourage you to be part of the fight. And thank you for your time.